Way to go, everybody. And Katie, I'll turn it over to you.
Okay. Yeah, I'm not sure how everybody else feels right now. I still feel kind of like a tightness in my chest, you know, after yesterday. So if you tried to reach out to me, I actually kind of took a little hiatus from the internet for a bit yesterday, just because I felt like it might be a good mental health move. I guess before we get started here, does anybody have any questions for Keith or for myself about what we're going over, the exam coming up on Friday, anything at all? Okay. Well, so today we're going to do a series of back-to-back lectures about epilepsies. It's going to focus a lot on drugs. So we'll be going kind of through a laundry list of drugs, especially I think the second part, our 1 o'clock hour. We'll be setting up a little bit about epilepsy, kind of how it's described in this first part of the lecture. And then again, we're going to get probably pretty deep into some drugs and just going through how the drugs are prescribed for different types of seizures, especially in the second part of this lecture. Like I said, yesterday for me personally was very stressful, and I don't know how you all feel. So if you're an animal person or a baby person, hopefully these pictures relieve some stress. I kind of took a page out of Keith's book here, so just to kind of start off, you know, maybe bringing down people's blood pressure a little bit. This is obviously my son who dressed up like a pumpkin and decided to just make a little mess. And then this is one of my cats. I've got 2 cats, one named Huxley and the other one named Steven. Quick funny story about Steven. Steven I rescued from Baltimore. Steven's actually deaf, which is interesting because I later found out from a neuroscientist that I worked with that there's a huge auditory research center at Johns Hopkins, and the model system that they use to study their auditory development is actually white deaf cats. So I always kind of like telling myself the story that Stephen was a runaway lab animal that found himself onto the streets of Baltimore. We've since rescued him, but he is his other senses are quite sharp, and he's a great cat, and I think is enjoying Montana. So again, the cats of NIM. Essentially, yes, it's kind of crazy. And given how much I've participated in research and not treated mice and rats so kindly, the fact that I could take care of maybe a possible runaway lab animal and give them a nice home, I think makes me feel a little bit better. Okay. Again, just a quick aside to hopefully lighten everyone's heart just a little bit right now. So the roadmap today, this is kind of a pretty general one. We'll be defining epilepsy, talking about some of the causes, talking about kind of how anti-seizure drugs, some of their targets, and kind of how they are prescribed, the classifications of them, the mechanisms of action, which kind of go hand in hand a little bit. And then we'll spend quite a bit of time talking about the drugs characterized according to their therapeutic uses. And so we'll get to kind of that laundry list of the different types, seizure types, and then we'll go kind of step by step through the different drugs that are applied to each one of those seizure types. Okay, so epilepsy, again, kind of giving you the rote kind of textbook description of it, is just recurrent and unpredictable occurrence of seizures. And so it's very much a symptom. So as you know, I was learning about epilepsies, it's kind of interesting to think of it as a symptom with various different kind of disease origins or disease states. So you're seeing this presentation of the symptom of the seizure, but there's a lot of different origins for that possible seizure genesis. And so we'll talk about some of the possible origins of that or the etiologies of that. And so what they have in common, though, is it leads to kind of this asynchronous, or synchronous firing, or that is unregulated within the brain, with a rhythmic firing of populations of the brain neurons. So it's kind of like you have the short circuiting of the system that happens, and then this rhythmic type of firing that happens. So when we talked about, you know, the introduction to the central nervous system, we talked about how important excitatory and inhibitory inputs are. And so this is kind of where that regulation kind of goes astray, where you have overexcitation of the brain. So if those breaks of the GABA, or, you know, the inhibitory circuits are essentially kind of taken off the system, how that can kind of lead to that reoccurrent firing of the brain. We won't be looking at a ton of EEGs because that's generally how this is diagnosed. I think we've got one maybe EEG slide in here, just kind of showing you what that looks like, a seizure would look like if you were measuring it. But again, it's just a kind of dysregulated firing. And we'll talk about how, where it originates and kind of where it spreads, kind of how that characterizes different types of epilepsies. But this is something that a lot of people suffer from. So it's very, I don't want to say very common, but it does have pretty high percentage rates. In terms of 3.4 million people in the US are affected. I think it says 2.5 in your textbook, but I think this data I'm giving you here is a little bit more recent. And approximately 1.1% of the world's population is going to suffer from some type of epilepsy. It is the most common, fourth common, most neurological disorder. I think it falls behind Alzheimer's, and depression. And then I think there's one other one I'm kind of forgetting here. But 6 in 10 people with epilepsy, the cause is unknown. So you can imagine prescribing drugs to mitigate the effects of epilepsy. It has to be very hard if you're not able to know what the, where the dysfunction kind of lies. And so you can't really do necessarily kind of a cause and effect type of prescription necessarily for epilepsy. You're kind of just trying to dampen down the symptoms that are being presented. And so when we look at the kind of effects of epilepsy, there's obviously going to be a lot to the individual. So there's going to be a transient impairment of awareness in some types of seizures, risk of bodily harm, depending on what they're participating in. So you can think of this as being pretty limiting if somebody has kind of recurrent seizures. So their ability to do things like drive a car or things like that. If you're losing consciousness intermittently, that could definitely inhibit your ability to do, daily functions that people might take for granted. Interfere with education and employment. Again, this is something that individuals don't have control over. So when and how intense their seizures are can really limit their ability sometimes. Again, and that's why proper diagnosis and then also prescription and finding kind of the right drug paradigm that works for them is so important. So when we talk about, again, I think of seizures as being kind of a symptom, but in terms of the origin of what the etiology of that, it could be, a variety of things. It could be genetic. So we'll talk about some specific genetic diseases that lead to different types of seizures. And those seizures may involve a variety of different genes. So those genes could code for GABA receptors. They could encode for sodium channels. We'll talk about that a lot. The syntaxin protein, neural adhesion proteins. So there's a whole variety or a slew of genetic mutations that can lead to different types of seizures or epilepsies. I just recognize that it could even be a combination of a few different mutations that occur. Second epilepsy that we have here could be some type of symptomatic disease cause that led to the presentation of an epilepsy. So some type of damage to the brain. So TBI, stroke, infections, brain tumor, developmental lesion, any way that you're essentially disrupting the normal firing patterns of the brain, you're basically opening yourself up to a possible misfiring and miswiring that would lead to those recurrent seizures. And lastly, that's another example here. It can be chemical or electrical stimulation. These are induced types of seizures. These are often the types of seizures that are used to study epilepsies. If you're not using necessarily a genetic model or a mouse model, you can use chemicals or electrical stimulations to induce seizures. So again, kind of drawing from my experience, when we talk about things like nerve agent exposure, epilepsies are very common in those in that world, again, because you're essentially causing this misfiring of the brain. And so nerve agents are a good example of a chemical stimulation that could induce an epilepsy. And I see Keith's face, so I think he has something to add.
Just real quick, like if you go back to the first slide there, where you're talking about 1%, if I'm not mistaken, that 3.4 million in the US would put that at approximately 1% also. So whether it's US or worldwide, 1% is a lot. And in another sense, to me, sort of naively, it's almost surprising to me that it's not more common when you consider the incredible number of coordinated things that need to occur for the brain to be functioning in an appropriate manner. But I guess that's been an adaptive sort of thing over evolution to keep the number down to the level it is. But anyway, that just struck me. 1%. That's a lot.
Yeah.
Thank you.
Yeah, but I think you bring up a very interesting point though about evolution and how I guess as a neuroscientist, you just sometimes have to marvel at the brain and the way that has it evolved to function so, smoothly and effectively a majority of the time. But I guess, that balance is so delicate that if you do anything to kind of knock it out of balance, you can see how epilepsy is, because again, it's sending all that electrical signaling for its purpose, to function. And so just the slightest, I think, just off balance in homeostasis can really lead to some pretty serious consequences. Okay, so again, these are some of the different causes. Again, when we're talking about epilepsy, it's kind of a symptom of the presentation of the different types of seizures. Okay, so ultimately when we're talking about anti-seizure drugs, it's, I guess, important to recognize that there's no prophylaxis or cure available. So there's really no curing a lot of the different epilepsies that we're going to see. But in terms of the mechanism of action of the anti-seizure drugs, and whenever you see ASDs, that's kind of what I'm referring to. I don't think you'll see it a ton though. It's not surprising. What you're trying to do here is you're trying to kind of ramp up your inhibitory and kind of dampen down your excitatory, again, because you've got that misregulation of firing. So if you think about it in that very simplistic way, then you can start to think about what you know about synaptic transmission and kind of how you would modulate synaptic transmission to either, ramp up inhibitory or dampen down excitatory. And so this laundry list that you see here kind of reflects that pretty clearly. So you've got, modulation of things like your sodium, potassium, and calcium channels. So if we think about how those relate to synaptic transmission, sodium obviously is going to, if you have an increase in sodium, that's going to lead to more action potential generation. So if you can block things like sodium channels, that's going to dampen down the system. And so potassium, again, kind of leaves the cell. So if you can kind of exacerbate that leaving of potassium, that's going to kind of, again, dampen down your resting membrane potential. And then calcium, again, is going to lead to neurotransmitter release. So if you block calcium channels, that's going to essentially allow for lack of synaptic release. And again, you'd probably want to selectively do that to excitatory neurons and not necessarily inhibitory neurons, because you still want to have your inhibitory neurotransmitter being released. So I guess for a second point here, again, enhancement of GABA neurotransmission, whether that's modulating the synthesis of GABA or causing more GABA release or prolonging GABA in the synapse, kind of similar to the mechanism that we see when we look at SSRIs. You can essentially do the same thing with GABA, is like you block the uptake or the transport of GABA, and you can kind of prolong the extended lifetime of the signaling of GABA within that synapse. You can also potentiate the postsynaptic receptors, the GABA receptors, specifically GABA-A. Again, that's the ionotropic receptor, and that's going to be kind of your fast neurotransmission receptor. So if you alter that postsynaptic inhibitory receptor, that's going to, again, dampen down the system, cause the brain not to be, it's kind of haywire. Third, modulation of synaptic release through synaptic vesicle protein SV2A, or the calcium channel containing alpha-2 sigma subunit. So you can see here, again, you want to modify synaptic release. So if you can dampen down synaptic release, you're going to dampen down, in most instances, the release of glutamate, and again, kind of prevent that excitatory neurotransmission from occurring as rapidly. And lastly, diminishing synaptic excitation mediated by ionotropic glutamate receptors, aka GABA AMPA receptors. AMPA receptors are going to be your primary ionotropic postsynaptic ionotropic glutamate receptors. So a majority of the fast neurotransmission that occurs in the brain is mediated by both AMPA and NMDA receptors, but because AMPA receptors kind of are the peak or the larger component of that, if you can negatively modulate AMPA receptors, that's also going to dampen down your excitatory neurotransmission. So again, very, very generally, when we talk about these anti-seizure drugs, if you think about, pumping up the inhibitory, dampening down the excitatory, that can help kind of calm the brain and hopefully get it back into its normal rhythm and firing patterns in a more regulated fashion. Just recognize when we're talking about these anti-seizure drugs, just because you're modulating these major pathways in synaptic transmission, there's going to be a lot of side effects that are going to be correlated to this, because you don't have a ton of necessarily selectivity in terms of where these drugs are acting at, right? You can't say, oh, there's a very focal seizure happening in the hippocampus, and when that drug is released, it goes directly to there. No, you're dampening down kind of uniformly across the brain. So it definitely has large effects to cognition in some instances. And so adherence can be a huge problem when we're talking about anti-seizure drugs. Okay, so again, kind of just keeping things very broad at this point, and we're going to get far more specific in terms of seizure classifications. But if we talk about kind of the two major classifications, you have focal and then your generalized onset seizures. So focal is kind of almost exactly what you would expect, right? You're beginning at a very local cortical site. It's not uniform across the entire brain, which contrasts with the generalized onset seizure, which has involved both brain hemispheres upon onset. So focal is just going to begin at one site in one hemisphere. However, with that being said, there are instances where a focal seizure can spread across the hemisphere and have a more, generalized appearance. And so I like this table. It's included in your text, and for a variety of reasons. First of all, it gives you kind of a great breakdown of both focal and generalized seizures, and then kind of giving you some breakdowns of more specific descriptions of focal, like with impaired awareness, focal with bilateral to tonic-clonic, which is kind of the description that I just gave you of a focal seizure that spreads. Focal with impaired awareness is when you're going to be losing consciousness, and we'll talk about that a little bit here in a second. Generalized absence seizure, those absence seizures are more commonly known as petit mal seizures, if you've ever heard that terminology. Sorry, I'm moving this around. The generalized myoclonic, perhaps a second of shock-like contraction of muscles. And we'll talk a little bit about tonic-clonic seizures here in a second. And then I guess that follows up the next point, generalized tonic-clonic. What's also great about this particular table is like we are going to go through this huge laundry list of drugs, but what this does is it breaks it down and tells you specifically where these drugs are applied. And that's kind of how the rest of this this lecture is going to be characterized, as what the type of seizure is, and then the drug that is applied to that seizure. And then this kind of compares and contrasts both the conventional anti-seizure drugs with the more recently developed anti-seizure drugs. And so you can kind of get that historical reference as to, 15, 20 years ago, kind of what was prescribed, and then probably what is a more commonly prescribed now. Again, probably not surprisingly, more of the common, more commonly prescribed anti-seizure medications now are more commonly prescribed because they have fewer side effects, because there are so many negative side effects that are seen with the kind of more conventional anti-seizure medicine. So again, when we get done with the entire lecture, I would recommend coming back to this slide and looking at this table so you can kind of put everything in context. And I think it would be really good for study purposes as well. Okay, so just kind of continuing and breaking down those, I see Keith's face, so I'm gonna pause for a second. Hey, Keith.
Sorry, I'm just disruptive, but the idea about the generality of action reminds me, I don't know if anybody saw this or not, but years ago there was a Dennis the Menace cartoon, and Dennis had a leg ache or something like that, and so he asked his mother if she couldn't give him a pain reliever to help it out, and she gave it to him, and it worked, and his leg ache went away. And he was just so amazed that he viewed the aspirin as a magic bullet, sort of a guided missile that went into his leg and solved the problem there, but didn't have any actions anywhere else. So unfortunately, in the realm of anti-seizure drugs, no magic bullets.
No, not yet.
Not yet.
But I mean, like, that's the exciting thing about research, though, is you see people who are trying to do focal drug release using things like ultrasound. So again, not perfect by any means now, but I think that's going to be really interesting to see where research goes. Okay, so just again, kind of taking that characterization, the very simple characterization we saw on this slide, and expanding it a little bit, which was included, I think, in that table. Again, focal can begin at a local cortical site. So can translate to a bilateral tonic-clonic, a second generalized seizure, where again, you've got that focal site that kind of spreads to that other bilateral side of both hemispheres. The focal aware seizures, in that instance, they're going to be staying conscious, and then your focal impaired awareness, impaired consciousness. When we're using the terms of things like tonic and clonic, I kind of just put stars here in case you're not familiar with this terminology. So tonic is going to be loses consciousness and stiffens, and then clonic is jerks. And those, again, are, I think, symptomologies that we're very, we think of when we're talking about, seizures. Generalized onset, it's involving both hemispheres. The tonic-clonic is going to present as both loses consciousness and stiffens, as well as jerks. And then the absence seizures, it's brief episodes of unconsciousness up to 20 seconds with no warning or immediate resumption of consciousness. And so this type of generalized onset seizure is going to be common in kids, and generally is going to resolve by the age of 12. It's what's interesting is when we're talking about epilepsies, we are going to talk a little bit about the difference in treatment strategies between adults and children. And something to just kind of take into account, Keith brought up that the legalization of marijuana just occurred. I will say that there has been kind of a push from the epilepsy community for this, especially for the treatment of individuals who have maybe idiopathic epilepsies, especially in children. Some parents say the only thing that works for them is the cannabidiol or even the THC to kind of, again, dampen down the epilepsies in their children, but that's kind of a whole separate discussion. It wasn't really included in Goodman and Gilman, but we can talk about that later if you like. Let's see. So again, just a kind of breakdown of those different classifications. Okay, so in terms of the mechanisms of action, we kind of talked about this, I think, when we talked about the anti-seizure drug slide. So I think I've hit this pretty hard before. You want to reduce synchronization. So again, that synchronicity that occurs when you've got that misfiring of neurons kind of pulsing through the brain, kind of loop. They generally almost look like loops. You've got this misfiring and you've got this whole like loop structure of this misfiring happening again and again and again. And then second, you want to reduce firing of action potentials. And we talked about kind of some of the molecular mechanisms that could cause that, which kind of leads to the second part of the slide, which is a little redundant, I think, to what we just discussed. So again, their mechanisms of action are generally targeting voltage-gated sodium, calcium, or potassium channels due to their roles in synaptic release. Second, you're enhancing GABA-mediated synaptic inhibition. That's by a variety of mechanisms that we had just discussed, whether it's promoting release, promoting time in the synapse, or potentiating the activity of the postsynaptic GABA-A receptor. And then modification of synaptic release processes. And again, that could be either excitatory or inhibitory, just kind of depending on the particular proteins that you're targeting. And then lastly, diminution of the glutamate mediated excitation. So again, hopefully if you don't remember anything from the first part of this lecture, you're kind of getting this message again and again. Again, these are the targets or the sites of mechanism of action for these epilepsy drugs. Okay, so again, just kind of breaking them down and showing you some pictorial representation. So when we talk about things like the voltage-gated sodium channel, I don't know how much we got into like the specifics of like how this voltage-gated sodium channel works, but again, upon voltage depolarization in a cell, you have opening of the voltage-gated sodium channel. And voltage-gated sodium channels are interesting because they also have these inactivation gates that kind of swing up and block the receptor. And by doing that, it prevents any further sodium from coming in. And so the sodium channel doesn't necessarily open and close as a kind of a traditional, you would think a channel would. You've got this inactivation gate that comes in and kind of blocks it for a second and then can unblock it. And then you have these other inactivated and activated states, which we'll see, I think, in further slides. But I guess the big thing to kind of recognize here is that this, again, gives you kind of a general characterization of which drugs are targeting this particular mechanism. So this gives you the laundry list of drugs that we'll be talking about here very shortly. And so what's hard is when we're talking about characterizations of drugs, you can either characterize them by their utility and how they're applied and used, which is kind of how this particular lecture is structured, or you can characterize them by mechanism of action, which is kind of what the information that you're getting here. So you can see just kind of, again, that laundry list, and we'll be talking about each one of these different sodium channel blockers and how they're applied to different types of seizures. Okay, I realize that I have been kind of going pretty quick. I'm going to pause for a second and ask if anybody has any questions. Hi, Keith.
Just basically a question for you, Katie. I don't know that much about these particular areas, but one tool that I've always sort of has helped me out is to think at least of some of these disorders as what they call channelopathies. And I don't know if that's a terminology that an electrophysiologist like you likes or not, but I just thought I might toss that out there as a piece of nomenclature that might be useful in terms of thinking about these disorders.
Yeah, I think that's a great point. I think channelopathy is, especially when we get to talking about some of the specific syndromes that have mutations associated with them, like Dravet syndrome, that's mutation in a sodium channel. So that would be considered a channelopathy. So a channelopathy is going to be when a mutation occurs in a gene that codes for a specific ion channel, essentially disrupts the function of that channel. So any type of mutation that would occur in a voltage-gated, sodium, calcium, or potassium channel that would lead to seizure genesis would be considered a channelopathy. And so they're, I guess, just kind of taking the next step into like research world, like there are many people who kind of take those genetic mutations that are characterized in humans, put those same mutations into animals, and are able to kind of essentially detect how those channelopathies affect synaptic function down to a single cell, but then they can also do it kind of in the larger, broader sense of basically putting an EEG on a mouse and seeing how those channelopathies affect overall function. And not surprisingly, a lot of those different mutations do lead to seizure genesis or epilepsies, recurrent epilepsies in those mice. But again, that's kind of an aside, but it's good though, I think, to kind of slow me down. But again, I just want to quickly remind you, I do keep my chat window open here. So kind of as I'm going through this material, if you do have a question and you don't want to necessarily unmic and you don't want to disrupt the flow, feel free to just pop up a question in the chat as well. Okay, so the second type of mechanism of action here that I'm showing you is the enhancement of the fast GABA-A mediated synaptic inhibition. So when we're talking about fast GABA mediated synaptic inhibition, we are talking about GABA-A, so the ionotropic GABA receptor. So you can see here a series of drugs that we'll discuss later and where they're targeting this particular mechanism of action. So you can see here the particular enzyme that converts GABA to succinic semialdehyde, and that breaks it further down into the metabolites. You can see vigabatrin and valproate are going to kind of target those specific enzymes. And so if you essentially block that, you don't get that same type of breakdown or metabolism of GABA in that presynaptic side. I mentioned earlier how there is essentially kind of an SSRI kind of equivalent drug that is used to prolong the time of GABA in the synapse. That particular drug that you see here, tigabalin, you can see targets the GAT1 transporter, and that's again going to block the uptake or transport of GABA, prolonging the lifetime of GABA in the synapse, and that's going to be able to bind, I guess, more readily to those postsynaptic GABA-A receptors. We've talked about some of these other drugs prior when we're in previous lectures, things like the benzodiazepines and the barbiturates, but as you can predict, there are some side effects to these drugs that are not necessarily necessary or desired in the case of treating epilepsies. Obviously, they're going to have some sedation effects, some loss of consciousness. And so that's going to be why some of those drugs aren't necessarily kind of the first drug of choice when we're talking about treatments of seizures. And then I guess kind of to bring all of these different mechanisms of action into a single picture of the synapse, this is taken, I think, from Goodman and Gilman. This gives you an understanding of both this is going to be your excitatory synapse, and this is going to be your inhibitory synapse. And you can tell that because you have your glutamate being released from this synapse and your GABA being released from this one. But recognize that because of that, you have a series of drugs that are targeting, let's say, the voltage-gated sodium channels in your excitatory synapse to decrease presynaptic release of glutamate. So there's kind of a laundry list of drugs here that do that. And then also you have drugs that can alter calcium channel function, as well as potassium channel function, calcium channel function. And then here you can see a particular transporter that's important for loading synaptic vesicles. So again, if you don't have a neurotransmitter in that synaptic vesicle, it's not going to activate your postsynaptic receptor as effectively. You can see that glutamate is released here, and then you have different types of drugs that target the postsynaptic receptor response. So here you can see felbamate is going to inhibit the NMDA receptor again, which is one of the postsynaptic receptors at the excitatory synapse, or parimental, which is going to again inhibit AMPA receptor function on the postsynaptic receptor. You can also see here a drug that kind of facilitates the loss of potassium out or the KC and Q channel. So again, lots of targets in both the excitatory and inhibitory synapse. And we're slowly but surely going to work our way through kind of each one of these and talk about them, not necessarily just in their mechanism of action, but also kind of how they're prescribed and applied. Just kind of moving forward down here on the bottom, you can see the inhibitory synapse. We've talked prior about the prevention of the breakdown of GABA by blocking this particular enzyme here, also blocking the uptake or transport through blocking the GAT1 transporter. And then also we've already kind of mentioned the potentiation of the GABA postsynaptic response by these other drugs. And so just recognize that, I guess what's nice about this particular additional part of the slide here is it's also including the presence of astrocytes and how those GABA T receptors are present on the astrocytes as well. Again, you've got, neurotransmitter transporters on both neurons and astrocytes. Astrocytes, that's again one of their major functions. So if you're trying to block uptake of a neurotransmitter, making sure that you can block it at both sides, I think kind of just exacerbates the effectiveness of that drug, because you're not necessarily just blocking your neuronal uptake, which is still substantial, but kind of one of the functions of astrocytes is to act as, I guess, conduits of neurotransmitter transport. Okay, so this is kind of where we kind of dive into the laundry list of drugs that are characterized by type of seizure they are used to treat. So we're literally going to go through the whole laundry list of drugs that are used for focal, partial onset drugs, and so on and so forth. So we're really just going to work our way through this. Again, because this is kind of a long laundry list, I tried to make the slides kind of similar to one another. And then I've also made kind of I'll just show you. The heading of the slide is a different color for each one of these different points. So when we transition to a different seizure type, hopefully that kind of draws your eye there, because again, these slides are going to become very repetitive, just kind of going over, over these drugs. Carbamazepine, again, very commonly prescribed, additionally used for tonic-clonic, but used for focal or partial onset. In terms of just recognizing that some of these drugs are going to be prescribed for one type of seizure, but can actually exacerbate other types of seizures. And so the case of this drug that actually occurs where you have exacerbation of the myoclonic and absent seizures, so it's not prescribed for those types of seizures. And in terms of the mechanism of action, this is a sodium channel blocker, the NAV1, which is kind of be that sodium channel that's responsible for APs. And so this figure here is nice, and it's going to be shown on the next couple slides, just because we have a lot of sodium channel blockers that we're talking about. But this is a nice review just showing you what an action potential looks like. You can tell that this slide was very much put together by an electrophysiologist, so I apologize, because they tend to get really excited about traces. So that's what we're looking at here, is in that blue is that action potential that's been recorded in a neuron. And so this whole rise that you see here is going to be those voltage gated sodium channels that are being opened. And so if you block those, you're not going to get that same kind of upshoot or of the AP. Now, as I kind of alluded to before, sodium channels are interesting because you've got this inactivation gate. So you can see here in the closed or resting state of the sodium channel, when it's open or activated, it's able to pass sodium through, and you don't have that channel, the inactivation channel really doing anything. And then during inactivation, you see that inactivation channel kind of close and swing close like a gate and kind of plug that sodium channel hole up, and then it has to kind of cycle back through. And so there can be a state where you have a closed channel and then kind of an open inactivation gate, but then once it becomes open, it opens up in both the inactivation gate and the channel itself is open, allowing sodium to come through. And then during the inactivation period, that gate closes, but the channel still remains open, if that makes sense. So it's almost like you have two different mechanisms that are mediating entrance of sodium. And so I guess the reason that point is important here is because some of these drugs we'll be talking about kind of delay the inactivation gate and prevent or keep that inactivation gate closed a little bit longer. So again, here you can see some of the sites in which I guess you have drug targets that can interact with these different components of the sodium channel. Okay, so getting down kind of into more of the pharmacology of this drug, again, the pharmacokinetics, just recognize that with some of these drugs, you're going to reach 100% bioavailability orally. It's going to peak around 6 to 8 hours, and the plasma binding protein is roughly 70%. It induces its own metabolism, and like many of these drugs, it's very much, you're going to be constantly adjusting these dosages depending on what the symptoms are essentially presenting. It is metabolized by the liver, the CYP3A4, as well as others. And again, you're just kind of getting a general sense of the dosage here. At the very end of this presentation, we'll be looking at kind of differences in serum concentrations of these different drugs, kind of a compare and contrast. So I think, again, that's going to be kind of a great way to pull all of this material together. So just recognize that in terms of drug interactions, this does increase the CYP3A4, so therefore increases metabolism of other drugs that might be co-prescribed. So unless this is being used as a monotherapy, there are other possible drugs that are could be being prescribed for dampening of seizure genesis, and therefore these other anti-seizure meds effectiveness can be altered by the co-prescription of this particular drug. And so it's important to just kind of recognize some of the different adverse effects: gastrointestinal discomfort, dizziness, blurred vision, diplopia, ataxia. Sedation occurs only at very high doses and rarely weight gain. And again, many of these drugs aren't prescribed for prolonged periods of time to maybe lead to adverse side effects such as that. But still worth definitely noting, again, you're kind of altering a pretty important channel that's affecting action potential generation across the brain. Okay, so other drugs that are used for the focal or partial onset. So oxacarbazine, again, I'm kind of left this particular picture here, and also does block voltage-gated sodium channels. The half-life is roughly 1 to 2 hours. It's less potent than the carbazamine that we saw in the last slide, but kind of can lead to hepatic enzyme induction. But there are very few drug interactions. Again, this is kind of the advantage of using this drug over the carbamazepine. Escocarbazepine acetate, this is essentially a prodrug. It's converted to its final drug state. It also acts as voltage-gated sodium channels. You can see the half-life here is much longer than some of the other drugs we've been discussing. The dosages are fairly high. It's eliminated renally, but does have little PK effect on the co-administration of some of these other anti-seizure medications that we'll be discussing today. So just recognize that that's something to definitely be taken into account is when we're looking at, you know, multiple therapies, kind of what the effect they might have on one another. Okay. Lacosamide, again, another sodium channel blocker, alters slow inactivation again. So we're talking about this inactivation gate here, and alters that slow inactivation and possibly prolongs it. It is widely prescribed, especially in individuals 17 and older. So this isn't necessarily something that's prescribed to children very often. But then you can see here the effective doses kind of range pretty widely. And then those higher doses are used to prevent that focal to bilateral exchange or movement of seizure genesis. Adverse effects: dizziness, headache, nausea, and diplopia. And then essentially is orally administered, but it does contain aspartame. So, so there are kind of other comorbidities that you might want to take into account if they have any type of metabolic diseases that would not allow them to break down or negatively affect their processing. Like we saw with some of the other earlier anti-seizure medications, it does have a high bioavailability but doesn't interact or inhibit CYPs. Okay. Just trying to keep my eye on the time to make sure that I don't go over and that we're spending our time wisely. Okay, so again, we're still kind of continuing to go down this list of these focal partial onset drugs. So phenytonin is kind of a very classical anti-seizure medication. We can look here where it was first discovered in 1938. So they were actually looking for a better tolerated barbiturate and kind of stumbled onto this instead. Also a sodium channel blocker, and then used for focal onset and tonic-clonic. It can worsen other types of seizures. So again, taking that into account and looking very carefully at the diagnosis when you're prescribing these drugs is very important. It can be prescribed with an extended release capsule. So that's one of the advantages of this. It can have several different administration routes. You can see that it can be administered orally, IV, or IM. The downside to an IV is that you do have edema or pain at the site of injection. So it's not necessarily kind of the most comfortable drug to be administered in that regard. And then the IM injection can be done. I think that's been done primarily in research models. It definitely comes off unpredictable and is not recommended in most instances. It is extensively serum bound, but can be displaced by other drugs. So it's important to recognize the drug interactions. And it also competes with other types of anti-seizure medications as well for these plasma proteins. So these factors may exhibit signs of toxicity when are within therapeutic range. So again, often with many of these anti-seizure medications, they're prescribed kind of at the low end and then slowly brought up in terms of their dosages, and especially when you're doing multiple therapies with this particular drug, you have to be very careful again, because you can have signs of toxicity even within therapeutic dosages. Is metabolized by CYP2C9 and CYP2C19 excreted in the urine. This particular figure is great because it's in your text, and it kind of talks about some of the first order kinetics and how this can be converted into there's saturation point where there's zero order kinetics. And so here you see the differences in essentially metabolism rates of phenytonin and gabapentin. So most anti-seizure drugs are going to have a pretty linear first order kinetic kind of, I guess, projection. But you can see here how phenytonin kind of differs from that. And because of that, that's one of the reasons you might see some of these toxic side effects at those lower more therapeutic range of concentrations. Again, just kind of continuing our discussion of this particular drug, you can see the plasma levels as well as some of the oral dosages. It can be administered as an extended release sodium salt. We've already talked about how it can be administered via IV. And in terms of kind of the long-term effects of being prescribed this drug is you can have coarseness of facial features and mild peripheral neuropathy, and some long-term kind of effects on vitamin D metabolism that happen. So again, this particular drug, and as far as being a co-therapy, has to be prescribed, I think, very carefully and look at the interaction with some of the other drugs, just because of the competition that it has, as well as its kinetic differences that we see between some of the other anti-seizure drugs. Okay. Other just kind of laundry list of drugs that are also prescribed for focal onset. This methylphenidatonin, ethatonin, and then the phenizimid. This last one here is actually withdrawn from the US. So any of the drugs that were listed in Goodman and Gilman or CADSUG that aren't really available in the US, I didn't go into like kind of extensive descriptions of, just because I feel like we have quite a bit on our plate here already. So I'm not going to have you maybe learn about drugs that might be irrelevant to our current model system, but that could definitely change. This particular set of drugs are not necessarily well studied and do have a series of severe interactions that are correlated to them. So not necessarily probably the first line of drugs that would be prescribed. You'll notice very quickly, again, because epilepsies are so idiopathic and so different for many people, that you'll find that people who have these diseases are often just kind of going through the checklist of like, okay, does this kind of mitigate my symptoms and not have negative side effects? And if it doesn't, if it does not, then they'll kind of continue to go through that laundry list of different drugs to figure out kind of what drug really works best for their particular kind of idiopathic presentation. Because like I said earlier, when we were discussing the causes of epilepsies, there's a large percentage of folks who don't know exactly what the cause is. And so it's hard to prescribe a specific drug that's interacting with that site to mitigate the epilepsy. Okay. Other drugs here, gabapentin and pregabalin. These are going to be analogs of GABA. So this is kind of a different mechanism than what we've been talking about prior. The mechanism of action of many of these prior drugs were those voltage-gated sodium channels. So here we kind of see a different approach. Analogs of GABA, interesting that they do not act through the GABA system though. These are used for focal seizures, neuropathic pain, restless leg syndrome, and anxiety disorders. They actually act through voltage-gated calcium channels, the alpha 2A sigma, and are going to essentially decrease glutamate release. So you're decreasing presynaptic release of the excitatory neurotransmitter, thus not leading to, more release of glutamate, less activation of those postsynaptic receptors, and kind of dampening down the excitatory signaling. You can kind of compare and contrast here the dosages of gabapentin and pregabalin. And again, it's interesting to note that these two drugs have a variety of uses, not just in mitigating seizures, and then essentially are not metabolized and do not induce hepatic enzymes, and eliminated unchanged in urine. Because they do appear so close to, or analogs of GABA are absorbed through the L-amino acid transport system, do not bind plasma proteins, and then have pretty short half-lives range roughly between 4.5 and 8 hours. The pregabalin and gabapentin kind of, they vary ever so slightly kind of within that range, but definitely both fall within that time point there. So again, just kind of interesting to note that they are analogs of GABA, don't activate GABA receptors, actually interact with those calcium channels, and then have a variety of other uses outside of just anti-seizure drug. Okay, so we've officially hit 11:49 here, so I'm going to pause again and ask if anybody has any questions, questions, concerns, general musings about the state of the world. I don't know if anyone wants to answer that last one, but.
I have a question. So over the course of treating someone who's had seizures, do you ever have to increase doses or change doses as channels kind of get stimulated by these drugs or blocked?
Yeah, so with a lot of these drugs, what you'll see, people see them prescribed at kind of their lower end, and then kind of over time, see them slowly ramped up. And I don't necessarily know if that's a product of their interaction with the receptors and causing things like downregulation, or if that's just more being conservative so you don't get all of those negative side effects in terms of like, possible cognitive function or loss of consciousness or things like that. So I think generally individuals are fairly conservative in the way these are prescribed, but I'm going to go ahead and I see Keith's face, so I'm sure he has something to add to this. And then for those of you who might be excited to log off, just recognize I've got 2 other questions that might be relevant to you that I'm going to answer from the chat. So.
No, I'm not going to take any time up now. If there's more time in the second hour, I have a kind of a unusual thing to say about phenytoin, but not right now.
Okay. One student asked how many questions will we have respectively on the exam, and it's going to be split 50-50. There will be 25 questions for me and 25 questions for Keith. And then the exam is on Friday, and that will be in Urey Lecture Hall. And Keith, just remind us again of the time for the exam on Friday.
I believe it's 3 p.m.
3 p.m. Okay. Yeah, so 3 p.m., Urey Lecture Hall, 50 multiple choice questions, 25 from Keith and 25 from myself.
I have a question as well. I was looking at your study guide, and it mentions like the receptors for each, like dopamine, serotonin. And I was wondering how much you wanted us to like know about those receptors, because I know it's like inhibiting AC, stuff like that. I'm like,
you're like, how much signal transduction do I need to know? Is I think what you're trying to ask.
Yeah.
Okay. You know, I think with a lot of these things, I tend to get a little buried in the details when I'm putting together slides. So unless I dedicate an entire slide to a particular receptor subtype and talk about its downstream signaling cascades, then that's where I would spend my time focusing on. But if I've given you just like a table and then all of those different, unless we've talked significantly about the type of signaling and what the downstream affects, then I would say don't stress out about it too much. I'm not going to pull like a single point off of a single table and ask you about it. Does that help?
Yes, thank you so much.
Yeah, hopefully that decreases your anxiety, because I know that there are some people who will write exams like that and be like, oh, well, I presented it. But ultimately, I think that the purpose of an exam should be to test the knowledge that we spend a majority of the time discussing, and not the minutia, I guess. The cutoff for Friday's exam material ends with Keith's material last week. And Keith, what was the last, was it the opioids?
Antipsychotics.
Antipsychotics, okay.
There will not be opioid on this exam, but the antipsychotic area was our last area of coverage.
Okay. Okay. So yeah, that'll start, I think, with the sedative, hypnotics, and there. Okay. Good questions. Could Keith clarify if parasympathetic drugs will be on this exam?
Well, technically it's coverage of the sympathetic, but all of that sort of blends together. So, you know, if there's some parasympathetic drug names that pop up on the exam, I wouldn't be too surprised about that. But the emphasis is on sympathetics for sure.
Okay, good questions for sure. I'm sure your fellow students are appreciating you're asking these questions. Any other questions or concerns before we let everyone go for this little break? Okay, well, definitely enjoy your lunch break, get some food. Think if you do have any more questions about the upcoming exam or the material that we're going over today. And I guess we'll see you here in a quick hour. So everyone have a good afternoon, or good hour. We'll see you very soon.